A healthy cross-section of human tissue relies on a highly structured architecture. At the surface, the epidermis provides a continuous barrier, while the dermis below houses the vascular and nervous networks, all supported by a basal layer of subcutaneous fat. When a mechanical breach occurs, this barrier fails, blood vessels are severed, and internal tissues are exposed to the external environment. What follows is wound healing, the precise physiological restoration of tissue integrity following this mechanical failure. Healing proceeds through a highly orchestrated cascade of 4 overlapping phases: hemostasis, inflammation, proliferation, and remodeling. The temporal scope of this response is extensive. The initial biochemical triggers fire within seconds of the injury, yet the final cellular resolution can require years to complete. Healing is an active, time-dependent continuum where the biochemical signals of each phase initiate the specific cellular machinery required for the next. This diagram illustrates the timeline of tissue repair. Looking at the top left cross-section, we see hemostasis. This immediate response occurs within seconds to hours of the injury. The localized crisis begins at the base of the wound, where the blood vessel has been severed. Platelets instantly adhere to the newly exposed, damaged endothelium of the vessel wall. Upon adherence, these platelets release a specific biochemical trigger, adenosine diphosphate, or ADP. The release of ADP initiates a chemical cascade, resulting in the formation of a fibrin mesh. This mesh binds the platelets together, creating a stable blood clot. At this point, the primary objective hemostasis shifts. With fluid loss stabilized, the fibrin matrix remains as a physical scaffolding supporting the cellular invasion. In the inflammatory block, we enter phase 2. A protective scab forms at the surface. This phase executes pathogenic clearance and releases signals to trigger rebuilding. Neutrophils clear bacteria, followed by macrophages, the cellular clusters visible here. The clinical signs of inflammation, redness, heat, and swelling, are direct physical byproducts of this dense, localized immune activity. Macrophages release the specific growth factors that initiate the proliferation phase. Consequently, inflammation is a required physiological prerequisite for repair. Those signals trigger proliferation, seen in the third cross-section. New blood vessels sprout into the wound bed, a process called angiogenesis. Simultaneously, fibroblasts migrate and activate, seen as the green structures synthesizing in the center. These fibroblasts produce collagen to physically fill the tissue void, forming uneven, pink structures known as granulation tissue. Finally, epithelialization takes place. Epithelial cells migrate across the newly formed granulation layer, directly beneath the protective scab, to close the surface wound. The proliferative phase prioritizes speed over structural perfection. It creates a functional but highly disorganized tissue patch that requires refinement. Refinement occurs in the final phase, remodeling, depicted in the fourth cross-section. Here, the disorganized collagen matrix is reorganized into tightly aligned fibers. Comparing the freshly healed layers to previous phases, you can see vascularity decreases and the scar reduces in volume. Healed tissue is a permanent architectural record of trauma. While the scar regains integrity, it is never identical to baseline skin, a permanent biological trade-off. The initial wound geometry dictates the biological workload required during the proliferative and remodeling phases. This split screen shows 2 clinical scenarios. On the left, primary intention healing has minimal tissue loss with tightly approximated edges. Because the gap is narrow, a minimal volume of granulation tissue bridges it quickly. Contrast this with the right side. Secondary intention healing leaves a wide structural void. This exacts a massive metabolic toll, requiring the physiological cascade to fill the entire crater with granulation tissue from the base upward. In some cases, clinicians use tertiary intention, a delayed closure strategy where a wound is left open to manage infection before allowing it to granulate. Clinical interventions like suturing serve a strict biomechanical purpose. By mechanically overriding the initial geometry of the breach, they bypass the exhaustive physiological demands of the natural proliferation phase. Even with optimal geometry, this highly orchestrated cellular choreography is vulnerable to microenvironmental factors. A moist environment is a requirement. As this simulation demonstrates, specific hydration levels are necessary to facilitate cellular migration across the wound bed. When the environment degrades through systemic low oxygen, poor nutrition, or uncontrolled inflammation, the repair process breaks down. These impairments stall the biological machinery mid-cycle. The body becomes trapped in a perpetual, destructive inflammatory state, leading to the formation of chronic wounds. Successful wound healing depends on the precise alignment of molecular signals, initial geometry, and external conditions to restore the integrity of the human system.